that we've learned over the last number of years for cancer patients is that a subset of patients have a change in their genes that make them more likely to develop certain types of cancers. Breast cancer is one of those cancers that we have learned the most about, where we know that there are certain mutations that people have in their genes that are passed through families that significantly increase the risk of breast cancer, as well as other cancers, often ovarian cancers, and then in men with those mutations, pancreatic cancer and prostate cancer. So one of the things that we always want in cancer is to prevent cancer from developing. It's always easier to prevent a problem than it is to treat it once it's present. So knowing that there is a genetic mutation in someone that makes them more likely to develop a cancer gives us a different set of tools medically to use to screen those people for cancers and to work to try and prevent those cancers from developing, or to catch them sort of as early as possible to ensure that we give them the best treatment options. So there's multiple layers to that. The first layer is that in the medical community, the science is changing pretty quickly. So the consensus recommendations about who should get tested are evolving, multiple times a year. The example I will use for this is in the last 12 months. The previous recommendation was any woman who was diagnosed with breast cancer at the age of 50 or younger should get hereditary breast cancer screening. That just changed to any woman who's diagnosed at 65 years or younger. So we just increased the number of people who should be getting that testing offered, and that can be difficult sometimes for the medical community at large to keep up with. So one reason testing's not happening is that the recommendations change quickly, and it gets missed, quite frankly, as those recommendations change. Another issue is sort of patient desire to get tested. So I don't know that our goal is that every single person get tested. My goal medically would be that every single person who's eligible for testing understand the testing and be presented with the option. And that's where, again, in busy medical practices, sometimes I don't think that we do a great job of presenting that full understanding of what it would mean to get tested, what benefit there would be to the patient and or their family members to get tested, and what the sort of consequences of testing would be. Testing children is a little bit of a more complicated question than it is to test adults, and there's a couple layers to that. The first layer is that in children, we really only want to test for genetic mutations that have a high likelihood of affecting them in childhood, meaning that having that change in their genes could result in something that happens to their body while they're still a child. The reason that that's important when we're going to test a child is because the child doesn't really get to make the decision about whether or not they want the testing to be done. It's the parent or guardian who's directing that testing. In adults, we really value autonomy as a key part of controlling one's own health, right? The job is to inform healthcare decisions, and each individual adult gets to decide whether or not they want to pursue genetic testing, for example. Children are not afforded that same autonomy. Parents make decisions for them. So genetic testing in children is a little bit tricky. We want to make sure if there's something that can impact their health as a child before they're adults and have developed that sort of higher level executive functioning where they can truly weigh the risks and benefits of testing for themselves, that we are intervening and doing everything that we can to protect their health as children. But if it's a genetic mutation that won't impact them until they're an adult, we typically do not test children, and we instead inform them once they are old enough to make their own decisions about the option for testing. So hereditary breast cancer screening typically falls into that latter group, where we rarely test children for the hereditary breast cancer genes, even if they have a parent who we know has that genetic mutation. But we would inform them as they, again, turn 18, become young adults about that risk, and then allow them the autonomy to make a decision about whether or not they want to be tested themselves. I think the most important thing is to be an informed patient. So this is an area of medicine that is changing rapidly, that year by year, the recommendations are different, our knowledge base is different, and the way that it can impact your individual health is different. So this is a type of medicine where I think it's worthwhile to try and look at consensus guidelines that are written for patients to understand. Like the American Cancer Society has sections of their website that are for patients about genetic testing, who might consider getting tested, what is the science showing, and it's a conversation to have with your doctor. And it's a worthwhile conversation to have at your annual physical. Has anything changed in the world of genetic testing that I should get screened for now that wasn't there a year ago? Just like you would ask, is there something different about treating blood pressure or diabetes, or preventing dementia or Alzheimer's? I think genetic testing should become part of the conversation for every patient to be aware that it is out there and that there are evolving indications that can help both individuals and their families have the most ownership possible over their health moving forward into the future.